Hi everybody and welcome back to lecture. So far we've talked about who is to be held accountable in the opioid crisis and how harm reduction offers a more humane and pragmatic response to drug use. Today we're going to bring it to the street level, looking at what happens in those critical moments before, during, and after an overdose. Specifically, we'll explore how Narcan is saving lives in real-time overdose situations, what safe consumption sites offer and why they're so controversial in the U.S., and the ever-evolving role of first responders who are increasingly on the front lines of this public health crisis. Let's go ahead and get ourselves started. Let's begin with a tool that's changing overdose response across the country: Narcan or naloxone. As we discussed in our last lecture, Narcan is an opioid antagonist, meaning that it can reverse the effects of an opioid overdose within minutes and is now available as an over-the-counter drug nationwide. What's new is how it's being integrated into everyday public safety. Police officers, firefighters, and paramedics carry it routinely. Librarians, teachers, and even bus drivers are now being trained to use it in high-risk communities. In some cities, you'll even find Narcan vending machines or free distribution centers in public spaces. Narcan doesn't stop drug use, but it does prevent death, and it gives people a second chance at life, treatment, and recovery. For many communities, that's an unquestionable win. Let's talk about the people who administered Narcan the most: our first responders. Firefighters, paramedics, police officers, and sometimes even library staff now are being increasingly trained to respond to opioid overdoses. In many communities, these responders arrive faster than ambulances do, and they're the difference between life and death. But while Narcan saves lives, it doesn't solve the larger crisis, and that leaves first responders caught in a cycle that's traumatic, frustrating, and often unsustainable. The emotional and mental toll associated with is unimaginable. You revive someone on Monday. You're called back to the same address on Thursday. The next week they don't make it. These are not rare scenarios. In some towns, EMTs are responding to the same individuals multiple times within a month. The result? Compassion fatigue, a kind of emotional numbness that sets in after doing repeated traumas. Moral distress is common, the feeling of doing everything right, but knowing that the system itself is broken. No follow-up care, no housing, no treatment slots. Resentment can grow. When responders feel like they're being asked to solve a crisis with only one tool, Narcan, and no long-term solution in sight. This isn't just burnout, it's occupational trauma in slow motion. So it causes conflicting roles. Am I a rescuer or an enforcer? Police officers face an additional conflict. In many places, they're both expected to save lives with Narcan, and they're also required to arrest people if drugs or paraphernalia are found at the scene. That sends mixed messages to both users and the responders themselves. Some departments have begun shifting toward Good Samaritan approaches, where those who called 911 for an overdose can't be prosecuted. But laws vary widely by state, and many first responders are operating without consistent legal guidance. So what are first responders asking for then? First responders aren't resisting Narcan. Many support harm reduction techniques. What they're asking for is systemic backup, including better training in addiction and trauma response. Protocols that connect overdose survivors to care, not just to ERs or to jails. They want mental health support for themselves, and in some cases, a non-police mobile response model, like Cahoots in Oregon, where mental health and medical teams respond to low-risk overdose or behavioral calls. This is where harm reduction and public safety intersect. If we're going to put responders on the front lines of a public health crisis, we have to treat them like public health professionals, not just as the dispatchers with Narcan. Before we move on, let's talk about those Good Samaritan laws that are popping up. They are an important but often misunderstood policy tool. These laws are meant to encourage people to call 911 during an overdose by offering limited legal protection to the person overdosing and the person who is calling for help. But the protections vary widely by state. In some states like New York or Rhode Island, these laws offer broad immunity from prosecution for possession and paraphernalia. In others, like Texas, protections are narrow. You must remain on the scene and cooperate with law enforcement. You're not protected if you've called before. And people with warrants or prior offenses may still face arrest here in Texas. This leads to uncertainty on the ground, where users may hesitate to call for help. Friends may flee the scene, and first responders are left navigating medical and legal priorities all at once. So while Good Samaritan laws are a step in the right direction, their uneven design often limits their effectiveness, especially in states with more punitive drug enforcement policies. Now let's turn to one of the most debated harm reduction tools, supervised consumption sites, also known as overdose prevention centers or safe injection sites. These facilities where people can use pre-obtained drugs under medical supervision with access to clean supplies, overdose reversal drugs, and basic health services. While these sites may sound controversial, here's what the research shows. No deaths have ever occurred in a supervised site. They reduce public drug use and improper syringe disposal. They increase referrals to treatment and healthcare, and they don't increase local crime or drug use despite common fears. These sites already exist in Canada, Australia, and several EU countries. And in 2021, New York City opened the first sanctioned site here in the US, reversing hundreds of overdoses in the first year alone. Still, they remain federally illegal under US law. The Department of Justice has the power to shut them down, and so far only a few pilot programs have been allowed to continue under local protections. Opposition to safe consumption sites usually falls into one of a few categories. Moral arguments, in which some believe these sites send the wrong message or normalize drug use. There are also legal concerns in which critics point to federal law, particularly the crack house statute, which makes it illegal to operate any facility where drug use occurs. And there's also NIMBYism, or not in my backyard. Local residents often object to sites near homes, businesses, or schools, regardless of the data. In Texas and other conservative states, the very idea of a sanctioned site is politically explosive. But in states like New York, Rhode Island, and California, local leaders are testing harm reduction infrastructure anyway, citing overwhelming evidence of lives being saved. This makes safe consumption sites a front line in the national drug policy divide between punitive enforcement and public health-based approaches. Let's close by reflecting on what we've covered today. Narcan is widely available, easy to use, and saves lives, but it's only a temporary fix. Our first responders are doing life-saving work on the front lines, often without the resources or the support that they themselves need. Safe consumption sites are reducing deaths and connecting people to care in other states, but remain off limits in most of the United States. And tools like the Good Samaritan laws vary by state, limiting their potential in places like Texas. This all paints a very clear picture. We've equipped some people to save lives, but we haven't yet built the system that helps people live. As I leave you, I just want to pose this question to you all. This isn't a formal assignment or anything, but just imagine this. Imagine someone in your community survives an overdose today. What would you want the next 48 hours of their life to look like? Who should be involved in that process, and what should come next? Next week, we'll pick up with alternatives to incarceration, drug courts, diversion programs, and policy experiments that try to offer the next step. Thank you all for your time and attention, and I'll see you all again next time. Thank you, and have a great day.